Okay, so welcome to everybody. Whether you've joined us in Click Meeting or Facebook to another question and answer session. Obviously, as usual, Collette, Thain, our CEOs, are hosting today. We're delighted to be joined by Professor David Jones. So both will be fielding your questions. I hope you have a very informative and interesting session, and I will catch up with you later.
Thank you, Alan. Thank you. David, thanks again. So just as we were waiting on you, I did say to people about your book, and Anne Balcom has said, brilliant book. So there you go. There you go. So I'll say to everybody again, we've got a lot of people in the room now. The numbers are coming, they're racking up quite quickly. So yes, do buy his book. And the book is patient friendly. It's not for doctors. They know enough. This is
well, that's a bold assertion, Collette.
It is actually. I'm just being nice to you lot. You've been looking after us.
You're very kind.
You've been looking after us so well. And David, just very briefly, I'm writing my editorial now for the Bare Facts.
Yeah.
And going back to that horrible, frightening moment when I was in my 30s, where there was nothing, nobody, and the names was Professors Jones, James, Newberger. Remember Ollie James Newberger, and Andy Burrows, of course. Just memories. Who's no longer with us. Anyway, right, David. I hope you've got your.
Just a note on that for everybody is that if you look at the last 25 years, the progress has been quite extraordinary across the board in terms of how people can live with it, how we understand it, how we can treat it, how people get treated. There's more to do, a lot more to do, but the progress has been astonishing. And that's come about by two things. One is the joint work of us and you and the doctors and the clinicians and the patients group and the foundation and their instrumental role in all of this. Really seriously. And then the other is people taking part in research studies. And actually, one of the things that people like me get to see is what the new trials are going to be, what the new treatments are going to be. And there have never been more interesting, potentially really exciting drugs being tried in PBC than we are at the moment. So if you think the last few years have been good, you wait and see the next year. So it's just to implore people that if a drug trial is suitable for you, if you're interested, these are all safe drugs. The system is really safe and effective, but they have transformed PBC, and we've only seen the beginning of it. And I think some of the drugs, particularly around itch, that are coming along are potentially game-changing, I think.
They are absolutely amazing. And I would say to people as well, I'm going to say to you more formally, I will announce this, but the PBC Foundation, along with our medical advisory, we are creating a database, a new database with your names on it. We want you to let us know if you want to go on the research database. So we're going to keep your names and your details and where you live. And then we hear of anything, we will let you know as soon as. So would you please start flooding Alan with, yes, I would like to be on your research register. Okay, he'll kill me for that, but never mind. But I will announce it formally. The
reason why that's also very important is that we work very hard to make sure that if there's an interesting drug that potentially we think is likely to work based on the knowledge behind it, I want those drugs to come to the UK rather than anywhere else, so that UK patients can benefit from them. And there is nothing that attracts companies to the UK like being able to do exactly what Collette just said, which is that we and the foundation, I tell all drug companies about. I mean, and drug companies make drugs. We work with industry because they're the people who make the drugs and develop them. And the foundation is the strongest possible sort of attraction to industry because of the connections to just so many thousands of patients. So and that means that all these sort of treatment options come to the UK, which is good for everybody.
Yeah, it's fantastic. So thank you for that. And as you all know, Chris is new to the post. He's just been inundated from pharma, which we sent you a chart of that. And it's difficult waters. Everybody's different. They've got different agendas and different wants and requirements, and we have to stick strictly within the rules. And patients first. Patients always first with us, as you know. Right. Okay. David, are you ready? You've got your brain in that. So, lady said she has blood test which shows raised LDH, lactate dehydrogenase.
Yeah.
There's a genital marker for tissue damage. Can this be related to PBC?
Yes, it certainly can. So, just to recap, A lot of the blood tests we measure in PBC, the alkaline phosphatase or the ALP-phos, the ALT or alanine transaminase, these are all enzymes. These are proteins that the body makes to do functions, and they're all normally inside cells. And when a cell is injured for any reason, they're all released from the cell. Okay, so, and you can measure the blood levels of them. And alkaline phosphatase, for example, everyone's familiar with that with PBC. That is produced by the cells that line the bile duct. And so when there's bile duct injury, then it gets released. And if there's less injury, less is released, and more injury, more is released. And that's why they're useful as tests. Now, we tend to think of those two or three. Lactate dehydrogenase, LDH, is another of these enzymes that is released by cells. It's a bit of an old-fashioned measure. So it takes me back to my early days in PBC. We used to measure LDH. We don't measure it anymore. So it can certainly be elevated in PBC. It's a bit non-specific. It can come from a lot of cells. It used to be a blood test for heart attacks, okay, because it's also released by heart muscle. So you can see why it gets a bit confusing. That's not to say anybody with a high LDH had a heart attack, but if somebody had chest pain and the LDH was up, that will be an example. It's produced by muscle if you have a muscle tear, for example, and it can be produced by blood cells. So it's a bit non-specific. It certainly goes along with PBC, and it's just worth bearing in mind that it can be produced by other things. But if you're measuring it in the context of PBC, if I saw somebody with a high LDH with PBC and a high ALP-phos, I wouldn't investigate it any further.
Okay. Right, great. I thought it was familiar, from the heart things. My late husband. That's a long time ago. Are booster jabs safe if you're pregnant? I assume it's the COVID jab. The booster, are they safe if you're pregnant? I
am not completely up to date with this, so I will say that. And I possibly, like everybody else, have a little bit of COVID fatigue. COVID itself is not a pleasant condition if you're pregnant, and my understanding is that the recommendation is to be vaccinated in pregnancy, but please don't take that as chapter and verse, because I'm not up to date with the exact detail about it. What I would say is, if somebody's been vaccinated already, and obviously you're talking about getting a booster, that implies somebody's vaccinated, then actually the booster simply re-exposes to something you've been exposed to. So it would be very low risk. So my strong suspicion is that's absolutely fine and to be encouraged because of the issues around pregnancy and COVID. They're not huge, but you just need to be aware of them. But do just check. And I think the answer is go to the booster session and tell them you're pregnant, and they will have the rules in front of them. So my gut feeling is, generally speaking, there's a rule in medicine, which is a healthy mother equals a healthy baby. So if in doubt, when you're pregnant and have an illness as a mother, then you treat that, and that's the best thing for the baby. That's almost always the rule of thumb. But as I say, the booster, by definition, you've already seen it twice, and so there will be no issues with it. But they're very much briefed. They're very much briefed at the vaccination centres about what's safe and what isn't. And just to go back to the debates about vaccination and things like that, I will say what I've said at many of these meetings is that there have been two health things that have transformed our society in the last 150 years. One of which is clean water to drink, and the other is vaccination. And I've also said, as I did my stint on the wards as a COVID doctor at the height of the first wave, and you really don't want to go there. I mean, that's not a place to go to. My wife is an intensive care consultant. She sees it even worse than me. Vaccination has changed the natural history of this. It takes it from being something which can be unpleasant and you can feel rotten with it, but it's it's taken something from it stopped it progressing from that to being something that's life-threatening. And it's a horrible condition if you get it now, and it's still a horrible condition, but it's not a horrible condition that will kill you, and that is as simple as that. So please do get vaccinated. And when you go for the vaccination, people are very well briefed. Do go through your history and things. And I booked my COVID booster because amazingly, and this will surprise people, I'm over 50, and I know it's a surprise, but it's true. I'm straight in there booking my booster. All right.
I didn't know you had to book, actually. We've got no notice up here, but never mind. Now,
well, but you've got masks and
watch it. I can still reach out on the screen. I'll give you masks.
And lots of rats in Glasgow, I gather.
There's lots of rats in Edinburgh. I'm coming to England. I'm coming to Northumberland 2 weeks for a whole week. No masks. Right, now this next one's an interesting one because I've had a word with this lady already. She's in Scotland. She was diagnosed with PBC 4 years ago. She tested positive with an AMA, and she was not put on URSO. She's had blood done quite recently and told she was a priority for a hospital appointment due to concern with her bloods. She was told by the hospital she may have to wait months for a priority appointment. Is there anything to do? Now, I had a word with this lady while I was walking in the rain, keeping my steps up. And her consultant up here in Scotland she's Scottish, but she's come up. She was in Cambridge and Birmingham, and her and I have had a nice long chat to get to know each other. So my suggestion has been that this lady go to the consultant or the consultant section and say she's had a chat with me, that she understands there's a waiting list, but could she go on URSO in the meantime? Her alkaline phosphatase was 190, and I think the gamma GT was 150. And I've said, because I thought that was a reasonable thing to suggest. Have you got any comments?
Well, I'm going to leave now because I'm redundant because you've just answered the question. So
but you have said the same thing. I like to know I've got it right, though.
I'm just here to add amusing sort of colour value to it. So you put it perfectly. One of the things that the community have done, and it's going to emerge somewhere fairly soon. So a group of us have got together to give some guidance, and there's a guidance document going to come out, which is how to approach the diagnosis and management of PBC in the COVID era to address precisely this. And it's very practical guidance. Marco was heavily involved. Marco Carboni, who a number of people
in Italy, yeah.
Yeah. So it was practical guidance to avoid us just ending up with a roadblock. Okay.
Brilliant.
And so what it says in essence is you do not need to reconfirm everything. So a traditional practice has been you'll get your blood test done by the doctor, then you'll go to the clinic, they'll recheck your blood test, then you'll come back with the results of that, and then you'll get started on treatment. None of those things ever change what you do, okay? And so in a time when it's more difficult to go to a clinic, we need to avoid those unnecessary steps. If people need a biopsy to look at the issues around maybe overlap, don't let that get in the way of starting treatment. So don't let the perfect be the enemy of the good. And actually, the wait with PBC should be once people are on URSO to see what happens with it. Almost regardless of what else is going on, if you've got PBC, you're going to be on URSO as the first treatment, and everything else will depend on what happens after the URSO. So don't wait to start URSO, go on to it, have the clock tick like that.
Yeah.
We also introduced a concept which I think is very important because people who've been on these sessions before know that I have a bit of an obsession about earlier, better treatment, and also making sure that everybody gets all the treatment that they should get, that we kind of just need to, speed the whole thing up. And we introduced a concept which I called first aid for PBC. So what would be first aid for a PBC patient? And the answer is, I think, and this is what the guidance says, it is absolutely fine for GPs to start URSO and prescribe it. It is entirely safe. It needs no monitoring. The only monitoring you need to do is down the line to see whether it's worked or not. And actually GPs can start it and then the follow-up to be in the hospital. So part of first aid for PBC is URSO. And then the other bit of first aid for PBC is Questran for itch, okay? Because obviously the itch can be very unpleasant. I don't think people should go beyond those two with
Right.
their GP, but those two are absolutely fine. They're both totally safe. Absolutely no issues about how you use them. They are not like steroids or azathioprine or some of these other drugs that the GPs worry about. These are literally treatments you can give to people and never cause any harm. And yes, in an ideal world, you get your first consultant appointment, you know, a week or so after the tests come back, you get started on the treatment that visit, and that's really good care. But we live in a difficult time, and actually the one thing you shouldn't be doing is waiting 6 months to start start the urso, and then those 6 months are actually part of your management. And I think you're very welcome. I would suggest you go back to either the consultant secretary or to your GP and say that you spoke to the foundation and they spoke to me about it, and this guidance is coming out around early commencement of UDCA without a full workup and catching up afterwards. And could you please possibly therefore start urso?
Excellent. Now the next quick question, when can I get the guidelines, please? I'll be first on your mailing list, yes?
Yeah. No, I knew when you asked me when I mentioned this, is I've no idea where they're up to. So I will chase that up and let you know. But I think it would be great for you just to disseminate that. They are designed to be handed to clinicians to say the experts in the field think that until things return to normal, this is how you should do it differently. And they were very common sense, and I don't know where in the system they are.
And as George Mell said to me, you know, doctors don't wake up in the mornings like, I'm going to be awkward with my patients today. Doctors are doing everything they can, and they're working in extraordinary circumstances at the moment. So,
I think, you know, a very small minority of people are bad doctors and are, you know, enjoy, you know, the power and all of that. I think the largest group of people are trying to do the right thing but aren't quite sure what it is, and we have been guilty of slightly overcomplicating it, which is one of the reasons why I'm obsessed about earlier, better treatment. There is a group of people who don't care, and I think one of the things that I worry about slightly around COVID is that I've seen a bit of a dropping off of caring from doctors, that everything we hear now about, you know, a lot of doctors is as about them and their pressures and their feelings and their things. And actually I come from an older generation where that's what you signed up to. And so I think there's more of a issue with people not caring, not amongst any of the people who you would recognize as being PBC experts. And we do have a network of people across the hospitals, the ones who look at people for ochre use and things like that. We have a fantastic network of really caring and nice people. The trouble is a lot of people are not looked after in that system, and I think if in doubt, if you aren't in general, if you feel that your doctor isn't interested or listening or taking on board things, then there is always a network to be moved on in the system to somebody who does.
And we can help people do that as well.
That's right. And Collette, you know, the foundation know exactly who the good guys are.
Yeah, we do indeed. Right, we've got loads of questions, David.
Yes.
I'm wondering if there's a link between PBC, vitamin B12 deficiency, and pernicious anemia. Is vitamin B12 deficiency, is that not pernicious anemia? They're not one and the same?
Yes. So yes. So the answer is yes. There is indeed. So pernicious anemia, which I always think is an illness that needs better marketing, don't you? I mean,
my dog's got it.
Yes. What makes your dog?
She's Jack Russell Corgi.
Right. Okay.
Rescue. Yeah.
So I always think that there's kind of anemia and there's the really pernicious anemia. So it's got a horrible name. Most anemia that people think about is caused by iron deficiency. So not enough iron in the diet or losing blood, you know, and so you have a particular pattern of red cells. Pernicious anemia is different, and what it is a lack of vitamin B12, and you need vitamin B12 to make hemoglobin. So it's not iron, which is in the heart of the hemoglobin, it's part of the process to make hemoglobin. So if you're short of vitamin B12, you can't make red cells as effectively, and so therefore you're anemic. Now the net effect's the same, you end up with you know, you can feel tired and washed out and so on and so forth. But it's a completely different problem. Now, the one thing you can't do is take vitamin B12 tablets, because the reason why you get pernicious anemia, and it was called that in an era when people didn't know what it was, because it was the anemia that never got better. You couldn't eat, you know, in those days, you know, cod liver oil and eating liver and, you know, this and
porridge,
using rich diet to get round anemia. Pernicious anemia wouldn't get better with that. That's why it was called pernicious anemia. The reason is, all of those things got plenty of B12, but the reason why you get pernicious anemia is that it's fact a problem in your stomach. So there is injury to the stomach, and the cells that produce a factor that you need to absorb vitamin B12 are damaged. So you can't absorb B12 in your diet. It's in the diet, but it stays in the bowel and goes all the way through. So it's bizarrely a stomach problem, and that is an immune injury to the stomach. So it's related to the mechanism of PBC. So people with PBC have this immune process. People with pernicious anemia also have another immune process, and that means that they're B12 deficient. And so, in fact, all you need to do is have injections of vitamin B12 every 3 months, and it makes the problem go away. This day and age, if you've had it for a while, there can be some irritation in the stomach, so they will tend to want to do an endoscopy just to make sure there's no mischief in the stomach. But it's really simple to treat, and it's just one of those things that's associated, and it is, of course, covered in the book.
Can you get that book down? Okay. Is high fluoride toothpaste safe for people with PBC?
Yes.
Okay. Lady has been described.
Yes, because you thought for a second I was going to give you a quick answer.
I was going to get in there.
Yeah. Just to make the point, yes, perfectly safe. And remember, because of the dry mouth problems, it's really important. Saliva is there to help keep the teeth clean. So just be really careful about dental hygiene if you've got PBC, because the dry mouth can make it worse. So it's doubly important to clean your teeth. And so a fluoride toothpaste is actually a good idea, not just an okay idea.
Yeah. Now, I'm going to make a comment about this before I get you to answer. The lady has been prescribed hydroxychloroquine tablets for Sjogren's. Are they safe to take with people with PBC? What I'm going to say to this lady, and David will answer that, is that that's only a small bit of a story. You could be taking 6 or 7 others or other medications, or maybe 2. But wherever you are with your medication, if you get something new, if you're unsure, yes, come and ask here, it's great. But always ask your chemist. These people come highly qualified. They've been to university. They know all about all the drugs, the connotations, the mixtures. And they're always delighted to speak to you and talk you through things. So don't forget that. So David, is it safe? Yes or no?
Yes. Just to echo that comment, pharmacists have an awful lot to offer. And I can tell you now, they know far more about the interactions and safety of drugs than doctors do. Okay. And one of the things that you may have read in the newspapers in the last couple of weeks is a move towards allowing pharmacists to write prescriptions. Okay. And this is a really important step. And this is about repeat prescriptions and things like that. And actually it will make the whole system work so much better, because they know this inside out. Remember, typically if you go to the chemists, you know, if you go to a Boots, or you know, other chemists are available, that you'll find the people behind the counter, and then, you know, behind the scenes will be a pharmacist. And these sorts of things, just ask if you could ask a question to the pharmacist, and they'll have a quiet room where you can go and do that, and it's really, really useful. Hydroxychloroquine, you will have heard of this. Donald Trump, of all people, we've mentioned Donald Trump in a PBC session. There you go. Donald Trump advocated this for COVID, as you know. Forget all of that. Hydroxychloroquine's been a drug used to damp down inflammation and arthritis for a long time. So we have a number of PBC patients in our clinic who take hydroxychloroquine, because we see a number of people with associated joint problems. So we don't see any specific problems with it. My only observation, and you don't take this as gospel, is that I don't think it's that effective in the type of joint problems PBC patients get. So we see a lot of people who take it, but they're not actually convinced it does much for them. And I suspect if you fall into that category, when you go back to whoever started it, that's the starting point for treatment for joints, not the end point for it. So it's a bit of an old-fashioned treatment. Now, old-fashioned treatments are fine if they work, but in our experience, it's just not a game-changing drug, and there are better options.
Yeah. And I know other people who take it for different diseases, and it is quite helpful. Somebody's asking, hello, do you know about the product from GSK for PBC? Is the GLISTEN trial? Yes, we do. And this person's saying it's a small trial out in the UK. It was given to 22 patients over a 2-week period. Even this time, a significant reduction in itch was seen, which is great. But yes, we do know about it. We've got various people on it, and watch out, there's going to be more of this. Yeah. Yes.
So the original 22-person study was done by some bloke called Jones.
Yeah.
Don't know who he is.
The author. That's right. The author.
Some bloke called Jones, some other guy called Mells, never heard of him either, and a guy called Hirschfield. So we do know a lot about it. So there has been a second, that was the first trial. There has been a second trial called Glimmer. And you can see where GLISTEN comes from. Glimmer is a phase 2 trial, which again shows the drug is effective. And then GLISTEN is the much bigger trial to work out where it sits in the range of treatments that we give. And so basically it blocks irritating bile acids being reabsorbed. And so it helps just bile acid. So it's like a much smarter version of Questran. In terms of its mode of action. Like all of these things, trials will tell us whether it's a useful drug. It's certainly a safe drug, and the early trials suggest it's beneficial. So it is one of the emerging trials which is kind of up and running in the very near future.
Yeah, so yes. Steve Ryder is on this in Nottingham. I know some of our people down at Queen's are back on this, and pleased to be so. So it's great. So thank you for that.
So I alluded to this. This is the new. We're now at the beginning of an era where people are going to target itch because itch matters, and I think that's very important. And I think there are going to be all we've ever wanted with itch, like all these things, is options to treat, because not all treatments work in all people. Not all treatments are going to be tolerated by all people. So you want to have options. So yes, it's a really good trial. And to be honest, it's really encouraging for PBC that companies like GSK want to be involved in it. And actually, Collette played a blinder in encouraging GSK to do this study way back.
You did not back yourself, David.
No, when we all went, and a couple of other patients just, managed to advocate for GSK getting involved in PBC, and I thought it was very, very powerful.
Yeah, it was
example of the true patient voice coming out. So it's been a really good story.
Yeah, we went down to Stevenage and GSK asked us, we were on a stage and there was David, 2 patients, one who was transplanted because of the itch, quality of life, and one who was about to be, and me. And this was beamed around all the GSK offices around the world. It was, as David said, it's very, very powerful. I'm going to keep talking fast. Okay, I have looked back over the years. I've kept my blood tests, and my C-reactive protein is usually elevated. On a more recent blood test, I noted it's still elevated, but now acceptable for a patient is printed on the sheet. Is the reactive protein elevated because of PBC, and is this normal? And I think that came with a separate sheet of the latest blood tests, which you have. Normal? Normal?
Yes.
Right.
So it's elevated. So it is a little bit. So there are 2 blood tests that we do that are very non-specific kind of heat markers. It's a bit like evidence of inflammation. So they're very kind of just run away. This means I can answer all the questions myself. This is fantastic. So CRP is C-reactive protein. It's produced by the immune system as part of inflammation, and it's elevated where people have any inflammation around. So it's usually seen at elevated levels where people have got a bacterial infection. But at lower levels, those are quite high elevations. At much lower levels, it's slightly up in PBC. The other one is a thing called the ESR, erythrocyte sedimentation rate. You'll often see that on your test. ESR and CRP are both often elevated a little bit in PBC. They, again, it's a bit like the LDH argument. If they're elevated, you don't need to look for other problems. It's part of the disease. But like a lot of these tests, if it's really, really elevated, so I think this value was about 10, where the upper limit of normal was 7, I think, if I remember correctly. When we're looking for somebody with a bacterial infection like a pneumonia, we're looking for a value above 100. So slightly elevated can be normal, but actually it's certainly normal for PBC. And it's just one of these things. It's one of the downsides of getting results just sent through without any context, because you get a flag next to them and nobody interprets it. But for us, we look at the whole context, and it's this issue of whether tests that are a little bit elevated matter or not, and that depends on what the test is. So it's one of those things where it's not quite as straightforward as just flags and no flags, and it's why I think sending people results is never a substitute for being able to talk about your results. I'm absolutely all for people.
Absolutely, yeah, and it happens a lot, David. It really does. It's quite common.
But you know, it's like we get asked every so often for people to have access to their medical records, and I have the hospital always say, "Are you happy with this?" There is not anything ever in a set of notes that I will put that I'm not happy for somebody to read, not ever. And we send all our letters to patients as well. However, if people are going to look at the notes, I would rather the opportunity to explain what things mean, because otherwise people can read too much into it. I was always remember back in the days when you got, nowadays there's no such thing as a chest x-ray, they all just go through a computer, but in the old days they were on the sort of wobbly plastic. And I always remember somebody who was given a chest x-ray to take from one clinic to another, and it was about 4 weeks between the clinics. And for 4 weeks, this guy, not a BBC patient, this guy was completely terrified because he looked at this x-ray out the packet and saw this big white blob, and he thought, "Doctor, I've got cancer, haven't I?" And I said, "No, that's your heart." Okay. And trust me, if you didn't have that, you'd be in real. But he'd lost 4 weeks of his life terrified about this. Whereas actually, if somebody said, "Those are the lungs, they're fine, that's your heart, that's normal," it takes 30 seconds.
Yeah. This goes, I don't know if this is a different question or not. I'm trying to clarify how best to take additional medication I've been prescribed for osteoporosis. I have to squeeze in one day 3 or so tablets. They can only manage 2 at a time and not 3. And OCA, 2 times 2 daily Adcal, and once a week a tablet of alendronic acid. Pharmacists have suggested a 4-hour gap. Great, you've spoken to your pharmacist, that's what we want. Between the Adcal and other medication, the same for the alendronic acid. Do I take them with or without food? Are there foods to avoid? There doesn't seem to be enough hours, and they take them all with enough time spacing. Please help. Can you suggest a timetable? I do suffer with acid reflux, so prefer not to eat late in the evening. And we've actually got a question on screen from Steph, also about stopping lansoprazole, including slow tapers. I was wondering if gastro reflux caused by having PBC or taking urso.
Yeah, okay. So not enough hours in the day. So the first thing to say is talk to the pharmacist. We talked about it. There are some drugs where how you take them makes a really big difference, okay? And there are some drugs where it makes much less of a difference than people perhaps think it does. There's always guidance given. And again, it's one of these grey areas where is the guidance kind of important, or is it just that you have to advise how to take it? So we'll go through these one by one. So urso, it doesn't really matter how you take it, okay? So urso is not particularly affected by how and when you take it. We tend to suggest to people take it in the evening. Sometimes people are given it as a split dose throughout the day, you know, three times a day, and that just trying to avoid 3 times a day tablets because they're a nuisance, but B, it means there's almost no hours you can find for other tablets. So we start people on night urso at night or in the evening, and it doesn't matter whether you take that with food or not, regardless of what the box says. It makes no difference. Okay. OCA, likewise, ochre you can take whenever it's convenient to take it. Like all of these things, ochre, it has actually most of its action in the gut, actually. So it works pretty quickly when you've taken it. And like all of these things, it's a kind of once a day medicine. So it's designed to be released quite slowly. The thing about urso and ochre is that if you for example, took them and it changed the way it was absorbed, we measure your response to them and adjust the dose. So it's a bit like warfarin for people who take it. It doesn't really matter whether you have a glass of wine or whether you eat food or, food, but know what I mean? Diet doesn't particularly matter. Alcohol doesn't particularly matter. What matters is changes in those. So what you need to do is reach now this is not me saying everyone should have a glass of wine in the evening. That would be wrong.
Oh, that's a shame.
Yeah, I know. But it's consistency. Chopping and changing is the problem. So get into a pattern that works for you. Then they check the blood test and then it all works out fine. So I would take, to be honest, I would take the ochre and the urso in the evening and in one big package. The one you've got to watch out for is alendronic acid, because it can cause esophagus problems. Okay, so it's quite irritant. So that's the one to stick religiously to the advice about how you take it, because and you've got to take it standing up, and you've got to drink water with it and wash it through. And the reason for that is that it can irritate the lower gullet if you don't. So of all of those tablets, the one that you've got to be careful with is alendronic acid. And then calcium and vitamin D, it doesn't really matter how and when you take it. It will cause a bit of irritation on an empty stomach. And so I would tend to take it with food. But again, they'll up the dose according to the effect. So I would not unduly worry about the timings for all of those, apart from alendronic acid, where you need to be quite religious about it, because if you get an ulcer in your lower esophagus, it's a bit of a nuisance.
Yeah, I'm sure. And sorry?
Lansoprazole.
Yeah.
We'll just talk about. So I think that people do get reflux. People do get reflux with PBC. I think it's the urso and partly the disease. So I think it can do it. And what lansoprazole is doing is simply kind of reducing the acid production and protecting the esophagus with it. So lansoprazole, that class of drugs, is incredibly effective for esophagitis, and it's probably made urso tolerable. Lansoprazole is, one of the safest drugs known to man. You can go and buy, it, in a supermarket. You don't even have to go to the pharmacy anymore. You can buy it in Tesco's. I guess my only question is, why stop it if it's giving benefit? If it's giving particular problems, fair enough. But if it's just that, you don't like taking lots of tablets, actually, it's a really safe and effective way of controlling that. And, esophagitis, long time ago, when I was a gastroenterologist, I used to talk to GPs about esophagitis and the problems it can cause, and we all think of it as a bit of heartburn and a bit of rich living and everything else like that. But actually, in those lectures, I used to talk about esophageal cancer and the risks of that with reflux over a long period of time. And one of those GPs, a couple of years ago, one of those GPs I spoke to came up to me and said he'd heard me talk about this, and by God, I was right, because they're now seeing an epidemic of this, and it's now disappearing with these treatments. So I actually would flip that around and say, why not continue with it? And there's a comment about, I thought it was harmful to take over a long period, only meant for short-term use. Absolutely not. We use these drugs long-term in people.
Great. First of all, thank you for previous advice to ask to be referred to a specialist centre. Referral done. There. I have cirrhosis and varices, and I have had a 13.5 random glucose blood test. I had a HbCA1 test, which showed as normal. I was told I was not diabetic. However, I have done some research, and am I right to think that with cirrhosis, this is a normal HbCA1? Result was a false leading GP to come to the wrong conclusion. Should I have oral glucose tolerance test if diabetic? How should this be treated? Well, obviously they would treat that for you. But is this person, I think they're basically asking, are they diabetic or
yes.
not?
So a really, really good question. A really good question. I liked it when I saw that one as one of the things, because I think it allows us to just talk about a few specific points. So the first is that there's no link between diabetes and PBC, full stop. So PBC doesn't stop you getting diabetes. It doesn't make diabetes worse. It doesn't mean you're more likely to get diabetes. So it exists. Although it's a very important thing to think about in people who are fatigued, because diabetes can make fatigue worse. So it's one of the things that we get people to look for. So it is important to look for it. Type 2 diabetes. Strangely, type 1 diabetes, which is the one where people start out on insulin, typically affects young people, is an immune condition, but it's an immune condition that has no association with PBC. So we talked about pernicious anemia being linked to PBC, but actually type 1 diabetes, which is also an immune condition, just has no link at all. We never see it, which I don't understand. Anyway, so type 2 diabetes is the one that's about, that typically is older people, perhaps being associated with being a little bit overweight, and can be associated with fatty liver. So we need to be aware of it, okay? So how do you diagnose diabetes? So this has undergone a real change, and the definitive test is the HbA1c, okay? And what that is a measure of how much of your hemoglobin has had a glucose attached to it, okay? It's a really clever idea, this, really clever. So it's glucose, if it's at high levels, or well, glucose generally, it will attach to the hemoglobin in your red cells. Doesn't stop it working, doesn't have any impact, doesn't have any effect, but it happens, and it happens in proportion to how much the glucose is, what the level of glucose is. But it does it 24 hours a day. So it is a 24-hour day, 7 days a week, 28 days a month measure, because it's the continuous effect of how much glucose there is. So a random glucose, like the 13.5 that you had, is a one-off measure which really reflects today and what you ate last night and what breakfast is. And so it's a one-off measure that could be completely different. And when I was a lad,
great memory you've got.
Yeah, exactly. Long time ago, we used to do this all on glucose values, and it would be very confusing. So the HbA1c essentially can't do it wrong, because it is a measure of actually what the glucose level was minute by minute over the last 90 days. So it's the effect of 90 days worth. So of those tests, the gold standard is the HbA1c, because it will be a direct measure of how much glucose was in your blood over the 90 days, which is diabetes or not diabetes. So if your HbA1c is normal, that's great news. You're not diabetic, full stop, and it doesn't need any more investigation. Now, why then was the glucose elevated? Well, that's because of cirrhosis. Now, when you talk about glucose levels, everyone always thinks about insulin. Okay, you eat a meal, your body produces insulin, and that's what brings the sugar level down. That's why when you don't have insulin, because you've got type 1 diabetes, you take insulin. So everything's about insulin. But in fact, insulin works by telling other cells what to do, and those other cells are the liver cells. And so if you eat a meal, the sugar goes up into the portal vein, connecting up to the liver. The loads of insulin is produced by the pancreas into the portal vein, and that then goes up into the liver together, tells the liver cells to take the glucose up, stores it as a short-term store as a thing called glycogen, and then in between meals, the glycogen gets broken down and the sugar comes out. And for those of you who've been to Snowdonia, to Electric Mountain, they have a giant reservoir at the top of a mountain, and during the night, when during Coronation Street or whatever, they let the water out, power the turbines to generate electricity very quickly. And at night, when the power stations are running but nobody's got their kettle on, they pump the water back up. So you have this constant flow in and out. That's like glucose into glycogen. If you look at your portal vein, when you eat a meal, the sugar level is very high. In between meals, the sugar level is very low. It's very up and down. And if you measure it in the normal circulation, it goes much more like that, because it's smoothed out by the effects of insulin and the liver, okay? And when you have cirrhosis, the insulin is normal, but the liver is ineffective at controlling it. So you see the same spikes up and down as you would do in the portal vein. So high glucose equals diabetes. Are you therefore diabetic? And the answer is no, because at the same time as it's high sometimes, it will go low at other times. And you've got to measure the average, and the way to measure the average is the HbA1c. And that's the answer. And a glucose tolerance test where you give people 75 grams of glucose and measure the blood at various different times, I can pretty much guarantee would give you an uninterpretable result, because it would be all over the place. It'd be really high and then really low, and it would bounce all over the place because of that spikiness. And HbA1c basically has replaced all of those things. And if you've got a normal HbA1c, you're not diabetic, full stop.
Great. Next one. Yes, no. Can you take HRT with PBC?
Yes.
And preferably the patches.
Yes.
A few questions coming in.
Am I allowed to just explain that a little bit more, please?
Very, very briefly.
Please.
Right, go on then, as it's you.
Yeah, so HRT, no, if you're using it to control osteoporosis, there are better ways of doing it, okay? Yes, if it's to control menopausal symptoms, because they're an important part of life quality, okay? So when we're looking at quality of life and fatigue and, you know, all of the other issues, we treat the treatable, and that includes HRT if that's relevant based on you and stage of life and things like that. So it can be an important part of the whole package of how you treat people. There are pros and cons of HRT. I'm not an expert on those, but people will talk about those. But our experience is it's a valuable part of the whole package people have, and is a good idea. What Collette was alluding to is because you don't want to expose the liver to too high a level, patch rather than tablet is one of the only situations where I'd use a patch rather than tablet. And so our advice is yes, HRT, if that's the right thing for you in discussion with your doctor, but out of choice, use a patch rather than a tablet.
Yeah, and it's indicative again, there's not always a yes, no answer, because as David said, discuss with your doctor, because each one of us is in different stages in our life, different medications, different conditions, etc. Now, this is quite a serious one, and as I say, we've got a few questions, we've not got a lot of time. Going through chemo for bowel cancer, and I've had upper thigh leg cramping. Do you think it's PBC? Chemo is Taxol and Herceptin. You must forgive me, people. My glasses are broken. I'm going to the optician next week. In fact, yeah, Herceptin. I had some steroids. Any tips or advice in both upper thighs? So I'm praying nothing to do with the blood clot. I'm in contact with oncology and DOC. I'm not sure what DOC. Oh, doc. But if you need to discuss this with them, whoever sent this in, if you're worrying about blood clots, you must discuss it with your team who are looking after you. Leg cramps, David?
I don't think they're particularly a feature in PBC any different to anybody else. We do see some restless legs at night, which can feel a bit like cramp. That is associated with PBC. We published that a few years ago. It's really difficult. I mean, chemotherapy has a number of effects on people. Clearly, anybody who's got cancer for any reason can have an increased risk of blood clots. And I'm afraid it's a case, nowadays it's done through ultrasound scans. It's non-invasive way of looking for it. And I think it's one of those things where you just need to let them know, get a scan and prove it isn't. If it isn't that, then it is likely to be the sort of change in chemicals in the blood associated with chemotherapy. So what chemotherapy will do is it will, alter the number of cells in the blood, and those cells release their own chemicals and things like that. Usually cramp is to do with salts in the blood, and so drink plenty and just avoid those kind of triggering movements that can cause it. I get terrible cramp in my right leg, and my wife gives me a kicking repeatedly because she knows exactly when it's going to happen, because I stand up from a chair in a particular way that is slovenly and lazy, as she puts it. So just watch out for that, but do drink plenty of water. But it's most likely just to be a consequence of all the changes with chemo, but do check for the
100%. Don't sit worrying about things.
Just an ultrasound. They can do it in 5 minutes. It's just an ultrasound.
I think this next question has probably been covered, and we haven't got time to give a lengthy answer, but what is the evidence for and against for continuing to take sequential combined HRT after starting on URSO? having done some reading, there seems to be some benefits for and against estrogen. Well, I think we've kind of covered HRT, estrogen.
Yeah.
It's a chat for this person and their doctor, isn't it?
Yeah.
Right, okay. I recently had to change to cholestyramine tablets instead of powder. I didn't know they had tablets. I no longer have my itch. Is this common? Wow, didn't know they had tablets. Did you?
Yeah.
Well, you should know.
Yeah, it's a tablet called colacevalam, okay?
Right.
Which is even more difficult to say and write than I can't spell it. I can't spell it.
I was going to say, can you give me a note of that? Don't bother.
Colacevalam is a tablet form of cholestyramine, okay? It's slightly bizarre because there's one trial of it in PBC itch which shows that it doesn't work. However, it clearly does work, as that person has just noticed and as we've noticed. So it does mean that we're not supposed to use it because it doesn't work, even though it does work. So it's one of those oddities. I think it's probably a little bit less adjustable than Questran, and it probably works a little less effectively. I think the physical nature of Questran means its gloopiness means that it actually works quite well. But colacevalam is something we try in people, particularly if they're struggling with Questran. So as people will know, most people who don't get the result they want with Questran, it's not because the drug doesn't work, it's because it's just so horrible to take. And they try the tweaks about chilling it and adding fruit juice and things like that. So colacevalam is definitely worth trying.
Excellent.
As an alternative, and of course it's very safe like Questran is, and it is certainly much more tolerable, but just a slight question mark about whether it's as effective.
No, brilliant. I'm pleased to hear that. Do different manufacturers of Verso put different ingredients in their tablets? My pharmacy sent various different brands of Verso, and there's one particular that upsets my stomach much more than the others. It's the coating of the tablet. There's the problem. All the Verso ingredients are the same as I understand it, but let your GP know so it won't be prescribed.
So exactly. So 90% plus of any tablet is not the active ingredient. It's filler, it's colouring, it's the coating. Okay, and those that you can get allergies to those, you can get discomfort with those, and the Department of Health will tell you endlessly that generic drugs are just the same as prescription medications, and that one generic is just the same as the other, and then it's not right. Okay, it's not the case because of all of those other factors, and we see this in transplantation with tacrolimus. You'll have, I'm sure, heard that, Collette, where people have had a transplant. We see it with inhalers for asthma, for sure, that people get good control with one but not with another, and so this can be an issue. The only way to be certain what you're getting is to get the Folk ursodeoxycholic acid. So Urso Folk, that's the only branded manufacturer, okay? And they produce it in the widest range of doses, so 300, 150 milligrams, 300 milligrams, and 250 and 500 milligrams. The 500 milligram tablet is very useful for people taking a big dose. It costs just the same as generic tablets, just the same. Generics price their medicines to be just a pence cheaper than the branded ones, okay? And they do that because pharmacists are obliged to use them because they're cheaper, but they're not meaningfully so. And this is where you get this whole farce about you can't get 300 milligram tablets because the factory in India is not working, and it drives us nuts. So the most consistent, reliable, easy to understand and predictable treatment is Ursofolk, which costs just the same as all other forms of ursodeoxycholic acid, and it's the one thing you know that month in, month out, you'll get the same treatment. And the pharmacist has to prescribe what the doctor writes, and if the doctor writes Ursofolk 500 milligrams twice a day, that's what you'll get. And if you are having problems with chopping and change, a lot of people don't, in which case it doesn't really matter. But if you are having trouble, then find what works for you. The one thing you won't be able to do is to find a generic type that works for you and expect you'll get that next time. I have high blood pressure tablets and they change constantly. Now, I don't get any particular problems with different brands, but I never get the same one month to month.
Okay, this is a quite simple yes, no. Does PBC cause low blood sugar drops like hypoglycemia?
No, other than it can do in cirrhosis, but to be honest, people can get low sugar for a whole variety of reasons. So people, sort of low level hypos can happen. So, I mean, I don't want to labor the sugar and cirrhosis, because 99% of PBC patients aren't going to get any sugar problems related to cirrhosis. So having a sugar, abnormality does not equate to cirrhosis, but it's not particularly part of PBC. And actually, a lot of women in particular can get, really quite low sugars for no particular reason.
Okay.
Because they typically live healthier lives than men.
For sure. I'm on RSOIU next month. Doctor told me that I had PBC in 2016, but it took me a long time to see a specialist. My numbers are coming down slowly. They've upped my URSO a month ago, but lost weight in the last year. I was 11 stone 9 and now 9 stone 8. And in your box of URSO, and we're going to be sending one out to you. The Falk Foundation are paying for. We've got imperial and metric measurement charts, people's weight charts. How much URSO you take. Check the box. It's on our website, how much you should be taking for your weight. How are you for time, David?
I've got about until 10 past.
Right, okay. So check or phone in, we'll let you know, but it's on the website. And I'm sorry you had to wait that long as well. HRTs have got, but how about estrogen cream? Estrogen cream, David?
Just give me 2 seconds. I'll free up 10 more minutes.
I know I've heard from your secretary, you've got a long day. David's working into the evening as well. I heard your finish is about 8, 9 o'clock tonight, David. So
it is.
Right. Well.
Right. Sorry. What was the question?
How about HRT is okay? How about estrogen cream?
Yes, absolutely fine.
Okay.
Just it functions just like. So it's the same concept as a patch. So remember, if you take a tablet, the highest dose will go through the liver because it gets absorbed by the liver, absorbed from the gut, goes into the portal vein, goes through the liver, and the liver will break it down. So therefore you have to have a high enough dose to mitigate from being broken down. If you put it in a patch or as a cream, it goes into circulation first. And so the dose is much, much lower for the liver.
Okay. Last question. Here we go. I know the liver is one organ that can heal itself, but I thought once the biliary ducts were damaged, they could not heal themselves, even if your numbers are back to normal, or can they? That's obviously, yeah. Yeah.
Okay. So 2 parts to that. So the liver is indeed an organ that will regenerate itself completely, and it's unique in that. I mean, well, skin does, but if you, for example, took half a kidney away for the rest of your life, you'll have half a kidney. Okay. So it doesn't regenerate at all. If you take half a liver away, then within 3 months, the liver will be back to normal. And we do this now reasonably routinely for people with cancer. So people in the past who'd had a bowel cancer and then had a metastasis in their liver, that will be regarded as an untreatable situation. Now, my surgical colleagues will routinely take half of somebody's liver, and it's really effective at it. And then 3 months later, the liver is back to normal. Okay. Amazing. So it is, and it's one of those blindingly simple things that nature does. Every single cell in our body produces a thing called hepatocyte growth factor that makes the liver grow. Okay. And so all cells in the body produce it, it goes into the blood and then travels to the liver, and it makes the liver grow. Okay. But hepatocyte growth factor is broken down by the liver. And so if you've got a normal sized liver, it gets broken down and has no effect. If you have a half sized liver, it doesn't get broken down, causes the liver to grow until it grows to normal level where there isn't any more. And it's so clever. Okay. So simple. So that's important if you have acute liver failure. That we see somebody with drug toxicity or something like that, because what you're looking to do is to support them to allow the liver to recover, because it will naturally recover. Very important in cancer, as we said. Now, within the liver, the bile ducts do and don't regrow. So PBC is not a disease primarily of the liver cells, it's a disease of the small bile ducts. Now, clearly, when somebody's liver regrows after you've removed half of it, they grow bile ducts. So the bile ducts can regrow, provided whatever is causing them to be damaged is not there. Now, what you're alluding to is that one of the key things in PBC is the issue of the bile duct injury. And there are some people where that can be kind of a dominant part of it all. So there are some people where, you know, damage to the bile ducts is really quite prominent part of the disease. What we think is, and this is where you are at the cutting edge, we are at the cutting edge of how you treat PBC, is that it's almost certainly easier to prevent bile duct loss than it is to reverse it. And if you're ever going to reverse it, to do that, you must create an environment where the disease is completely controlled, okay? And this is where the whole approach of waiting to see what urso, waiting for an appointment and waiting to go to the clinic and waiting to get your blood tests and then waiting to start urso and then waiting to see how you respond to urso and this, what that does is introduce years and years and years. And the worry is that if that is associated with the bile ducts being injured, that may not then be reversible. So we may be missing an opportunity to treat it better, okay? Now, the very good news is that the UK, and Collette knows about this, but she knows doesn't know I'm going to say this because she didn't know until now that I could say this, is that we have just got collectively £1.5 million from the Department of Health to the various different funding bodies.
Wow, we did! Oh, fantastic! Congratulations!
To do the trial. And what that is to take people other than those with really low risk and to give them a obeticholic acid from the very beginning of the disease with urso. So on day one, you start on definitive treatment. The whole idea behind that is to prevent the injury from the bile ducts becoming progressive. So rather than wait, and then treat it, identify people at the beginning and start them on the right treatment and just continue with it. And so that's the good news. It's the first new approach to treating PBC in 20 years because we're going away from the giving urso and waiting, see what happens. We're going to treat people better from the beginning to kick the whole disease under control. We think, and there's a whole load of evidence behind all of this, but we think you can actually switch the whole disease process off, and that's the idea that we're working on. Now, there's going to be much more information about this and press releases and things like that. What it's going to mean is it's going to be really important for that trial that this is all about people newly diagnosed with PBC. So we need to see people within 3 months of having PBC, because that's when you need to do this treatment. So it's going to completely change the model for what happens to people. What it will have is the beneficial effect is that it will make people move through the system much faster. So people will go straight to the PBC centres to be managed because they'll be offered this trial. No, you don't have to take part in it. People will be offered this trial, but you won't have to wait to get obeticholic acid until you've kind of failed urso. It will be, part of the trial from the very beginning. And we've got a new blood test that we think may well be able to help us understand who can benefit from all of this. So I've said it many times that when I started in all of this, it was inconceivable to me that you could cure PBC. Because and I'm joking apart, this really is in the book in real detail. And I thought that we'd never be able to cure PBC because once bile ducts have gone, they don't come back, okay? But what we hadn't realized is that the bile ducts haven't gone. They have just gone into a form of suspended animation, a zombie state, okay? And what this treatment is aimed at is from rescuing those cells. So actually, there is a sort of halfway house between dead and alive, which is on the route to being dead, but is salvageable. And that's the whole concept, is that we think that part of the limitation of current treatment is we just wait too long. Creates complications, it makes the whole thing slow. And actually, we end up doing 5 years down the line what we knew we were always going to do at the beginning, in which case the obvious question is, why don't you just do it? And maybe we should call this the why don't you just do it trial. So keep your eye out for that.
I am so happy. I'm very tearful. I'm so delighted.
It's the big one because it's the curing PBC. It's the big one.
Waiting for.
It's the curing PBC trial. Sorry, I shouldn't have ambushed you like that, but it just
no, it's fine. I don't mind people seeing I've got a heart because you cannot believe this is
PBC. If we can get it early enough, PBC is a curable disease. Okay, but the art is is getting it. It's like the old joke, you know, say to me, Collette, say to me, what's the art of comedy?
What's the art of comedy? Sorry?
Do it again. Say it again.
What's the art of comedy?
Say it again.
What's the art of comedy? What?
You're saying to me, what's the art of comedy?
Yeah.
Which the answer is timing, but I'm saying timing in the middle of you saying that, which is the timing has got wrong. It's a not very good joke. The art of PBC is timing. Okay,
David, I'm just, as I say, right through bare facts and where this journey started. My journey in 1994, there was no ortho, there was nothing. And I'm so happy. David, thank you for giving us extra time. We're not going to see David now. Maybe December. You're not in November. Well, I'll have a look at dates and things. I know but thank you so much. I'm going to let you go, David. You've been wonderful today. Thank you.